The lights are off, 3 monitors, and the glow of a mammogram you pulled up 40 seconds ago. A small white star sits in healthy tissue. You've read 10,000 of these. This one is cancer. You are the first person on Earth to know it. The woman who came in this morning feels fine. She's already back in the parking lot. You type one sentence, you sign it, and open the next study. Her name is gone from your screen before you've finished the thought. You'll never meet her, never learn how it ended. Half of all patients never find out you exist. Level 1. Medical student, $200,000 in debt and 4 years from a paycheck. You're halfway through your 3rd year, rotating through the hospital, and nothing has fit. Surgery is brutal, clinic is slow. Then one afternoon, you end up in a small dark room off a basement hallway, standing behind a radiologist scrolling through a CT. He stops on a single slice, points at a gray smudge you would never have caught, says one word, appendicitis, before the surgeon 2 floors up has finished the exam. Then he pushes the mouse across the desk and tells you to find the next one, 22-year-old man, pain in the right lower belly. You scroll. The slices slide past, gray on gray. You go through the whole abdomen twice and see nothing wrong with any of it. He takes the mouse back and rolls it up 4 slices. There it is, a tube that should be thin and isn't, with a haze around it. It had been on your screen both times. He does it again on the next study and the next. The whole hospital is upstairs asking questions. The answers come from this little room. You spent 2 years in libraries for a shot at a room like that. Step 1, then Step 2, the licensing exams that quietly decide who matches where. Radiology isn't the safe backup. It was a generation ago. The scores it takes to get into the dark room climb every year, and you have them. You apply that fall, and radiology turns out to have a rule no other field has. You match twice. One list for a preliminary intern year in plain medicine or surgery. A second, separate list for the radiology program that won't start for another year. 2 envelopes on match day, sometimes 2 different cities. Your classmates going into surgery picture themselves gowned at the table, hands inside a patient. You pick the one clinical specialty where the patient is mostly a name on a work list and a reason for the scan. First, the year they let you near them. Level 2. Intern. About $60,000, and for the first time, the word doctor in front of your name. You don't read a single scan this year. Radiology calls this your prep year and then pretends it barely happened. You're on the medicine floor at 5:30 in the morning, pre-rounding on a list of patients before the attending shows up. You draw the blood, you chase the potassium. When a man in bed 11 goes gray at 2 in the morning, you're the one in the room with both hands on his chest. In March, you admit a woman who can't catch her breath climbing 1 flight of stairs. You listen to her lungs. You sit on the edge of her bed and tell her what you're worried about. Then you order the CT. An hour later, a report comes back with 1 sentence in it that changes her whole year. You pull the images up on the floor computer and stare at them, and you cannot see the thing the sentence describes. Somewhere in the exhaustion, you sit Step 3, the last licensing exam, in a windowless testing center on one of your few days off. You pass it and barely remember the room. It's the final box checked before you're allowed to vanish into radiology. The hours are punishing, and you are quietly exactly where you belong. The residents around you want to manage the patient through the next week. You want the one thing the picture isn't saying. You think in findings, not plans. And the people who think the way you do, you finally found them. Then June ends. You hand off your patients, turn in your pager, and your badge comes back with a new title. The next Monday, you sit down at a workstation in a room with no windows. The first study loads, a study number, an age, and a clinical question typed in 9 words. No face, no name you'll remember. You will not sit on the edge of a bed again. Then they turn the lights off for good. Level 3 Radiology Resident. $68,000 and a year of being wrong out loud. Everything you say is overread. You look at a chest film, you call what you see into the microphone, and an attending beside you names the 4 things you walked right past. Your first week, you read a chest film is clean. The attending leans in and circles a faint shadow tucked behind the heart, the blind spot where the anatomy overlaps, and a small cancer can sit unseen for a year. You would have sent her home. The grammar of the report gets drilled in tight, hedged, exact. You learn that clinical correlation recommended isn't a cop-out. It's the honest seam between what the image shows and what you, sitting in the dark, can't possibly know about the person it came from. Then an attending is busy one afternoon and a study is yours alone. A clinician reads your sentence and moves, orders the biopsy, starts the drug, calls the family. Your words left the room and turned into something that happens to a body. Nobody claps, the study just clears, and the next one loads. The volume climbs every month, and you rotate through the whole field to earn it. A block on chest, a block on neuro, a block down in the pediatric reading room, each one its own language. First, it's chest films and simple scans, then ultrasounds, then the cross-sectional work that takes real time to read. By your second year, you're clearing dozens a day, and you've started to trust the small voice that says something here is wrong. Then, in your third year, the entire specialty arrives as a single exam, the core. 17 categories across 3 days, every organ, every machine, and the whole of medical physics, which you will never touch at the workstation and have to master anyway. For a year, you study at dawn before the list and again at night after it, drilling image banks until the patterns burn in behind your eyes. Somewhere in there, the room stops being a place you visit and becomes yours. You order your priors, set your layouts, scroll 1,000 slices a day, and you've stopped noticing the lights were ever on. And you've quietly become a particular kind of person, one who can be wrong in slow motion, wrong in a way that doesn't show today, that grows for 2 years inside a chest while everyone moves on. You haven't done it yet. Then they hand you the night. Level 4, the night read. Independent call. The same paycheck and the building goes quiet around you. Same badge, same residency, completely different job. Halfway through residency, they cut the cord. You take overnight call alone. The only radiologist in the hospital, issuing reads the emergency room acts on within minutes. They call it a wet read, from the years when film came out of the developer still dripping. The attending sees it in the morning. Until then, it's you. 2 in the morning. A trauma scan lands, a young body, head to pelvis, captured in one pass. The surgeons are standing in the trauma bay, waiting on your words to decide whether to open him. You scroll. There is no one beside you. There is no one to ask. Overnight imaging has climbed nearly 300% in 14 years, and all of it funnels down to one tired resident at a time. It isn't just trauma. A stroke scan, where every minute is brain. A child with belly pain at 4 in the morning. A grandmother short of breath whose chest holds the reason. Each one gets a preliminary read that someone downstairs acts on before sunrise. You could pick up the phone and wake the attending. Most residents won't, not out of arrogance, but out of the small private fear that calling for help means you couldn't handle it. There's a real case every resident hears about. A resident on call sees a bright spot in the lung vessels and calls a massive clot. The team moves fast, clot-busting drugs, a breathing tube. Morning comes, the attending pulls up the study, and it was never a clot. It was an artifact, a trick of the physics. That is the whole weight of the night, pulling both ways at once. Overcall, and you send a stable person toward a dangerous treatment. Undercall, and you send a stroke home to sleep it off. Each mistake has a face you will never see. In a few years, you'll be the attending the residents are afraid to wake. You'll remember being the one afraid to call. Survive enough nights, and they let you choose the single thing you'll look at for the rest of your life. Level 5, Fellowship. About $80,000 and the whole field narrows to a slice. One more year, and you specialize. Neuro, brains and spines. Musculoskeletal, every joint and break. Body, chest, nuclear medicine, children. Or breast imaging, where the entire day is the hunt for one thing before anyone can feel it. You stop being the radiologist who reads everything and become the one the department pages when the picture won't resolve. Getting here meant another application cycle, another rank list, another move. The third time, the system has sorted you and sent you somewhere new. The shift is small and total. One morning, a senior attending turns a study toward you and asks what you think, and actually means it. You're the reader now. In breast imaging, that one find becomes the whole day 50 times over. Screening mammograms stack on the work list. Women who feel completely well, in and out on their lunch breaks, gone before you ever open the images. Most are nothing, and you clear them in seconds. Then one isn't, and the room goes very quiet while you grade it suspicious. A 4 on a 5-point scale, one step short of certain. Most of the women you call back turn out to be fine. You call them back anyway, because the alternative is letting the one walk out the door. So Thursday afternoons, you run the callback list, and for a few hours, the job has a face in it. Extra views, an ultrasound, a needle under the skin with the probe in your other hand, and a specimen dropped into a jar for the lab. A woman on the table asking you what you can see close enough to touch. You tell her the pathology will take 2 days. Then you go back to the dark. Level 6, attending. Median pay around $510,000, among the highest in all of medicine. You earned the dark room, and the dark room comes with a list. A year after residency ends, you sit one last scheduled exam, the certifying exam, and the words board certified finally become true. The work list is already 40 studies deep when you sit down at 7:30. You read across all of it. Plain films, a belly CT, a knee, a brain, a spine MRI, dictating each one into the mic and signing it off. The number people quote is 80 to 100 studies in a day, though a day of plain films and a day of complex scans are not the same animal. Lunch is a thing you mean to get to. You clear 90, look up, and the list is longer than when you started, because downstairs the scanners never stopped. Where you do this decides the texture of your life. Make partner in a private group and your name goes on the door, the pay climbing into the high 6 figures. You buy in first, a few lean years of proving you're worth a full share. Stay in academics, and it's lower pay, residents to teach, papers to write. Or go fully remote, a teleradiologist in a blacked-out spare room at home, reading for hospitals 3 time zones away, a doctor who has never once walked the halls of the place he keeps safe. Every study on that list is the worst day of somebody's year, and it gets 90 seconds. By the 90th scan of the day, the patterns come automatically. The work is holding the same care for that one that you brought to the first. And every so often, the screen pays you back. A man comes in for back pain. In the corner of the scan, on a slice nobody was thinking about, sits a small kidney mass, caught a year before it would ever have announced itself. You made that catch, and it took you 10 years to be able to make it in 4 seconds. 10 years of this, and they stop asking you to read faster. They start asking you to run the room. Level 7, senior attending. Then comes section chief, and you run the same reading room where you once took overnight call alone, too unsure to pick up the phone. The day starts before you open a single study. A technologist calls up from the scanner asking how you want one protocoled, with contrast or without, how thin to cut the slices, whether to run a second pass a few minutes later. You answer 4 of those before 7:30. Then you overread the resident's overnight prelims. Some mornings you're the one who catches the artifact they called a clot, the same save an attending once made over your shoulder. At 9, you're at tumor board, in a room with the surgeons and the oncologists, putting the scans up on the big screen and saying out loud what the tumor is doing and whether it has moved since March. Nobody in that room can make a plan until you talk. The rest of it comes at you sideways. A radiologist down the hall rolls his chair back and asks you to settle a liver he can't call. You teach the noon conference, you sign the schedules, sit on the hiring committee, and argue with administration about a scanner that needs replacing. And on Friday, the month's misses go up on the screen for the whole department, including yours. You spend a year teaching a resident where to look, and one night she catches a quiet bleed, you would have caught yourself. Some of the reward moves there. And the boards never fully close. Every week, a question or two lands in your account. Continuous certification, the profession's quiet way of making sure you keep reading the journals until the day you retire. There is one thing you've been hearing the entire time you've done this job. Back when you were training, the most famous machine learning researcher alive stood up and said people should stop training radiologists now. Within 5 years, he said, the computers would read better than any of you. He called the radiologist a coyote already off the edge of the cliff, just not yet looking down. A generation of students heard it, and some of them picked another field. It didn't happen. A decade on, there aren't enough radiologists to read the world's scans, one of the worst shortages the field has ever faced. The volume per doctor climbed by a quarter. Salaries climbed with it. The researcher himself walked it back and admitted he'd been wrong about the timing. The machine turned out to be a tool that flags and measures and sorts, and it still needs the person who knows the easy case only looks easy after 10,000 of them. The chair came with a different cost, and you didn't see this one coming at all. The higher you climb, the less you read. You sign more than you scroll now. Some weeks go by without a single study you were the first person to open. The lights are still off, you run the place, and you still can't see the patients. It's 7 at night, and the room has emptied out. The residents have gone home. Your inbox is full of schedules and hiring paperwork that will still be there tomorrow. You pull up the work list anyway. One study. A chest CT on a 54-year-old man ordered for a cough that wouldn't go away. You turn the lights the rest of the way down the way you like them, and you start scrolling. Somewhere around slice 90, there's a nodule in the upper lobe, 5 millimeters across, and you stop. You type one sentence, you sign it. Right now, he's on the interstate driving home with the radio on, and he still thinks he came in for a cough. In 11 years, he'll be standing at a wedding. He will never say your name because he will never learn it. That's the trade. You made it years ago in a basement hallway with somebody else's mouse in your hand. The cursor blinks in the dark, and the list refills.